Okay, so what is CLL? Well, first of all, just to start with the terminology, because the word leukemia is obviously can be quite frightening when you first hear it. So it actually comes from the Greek, it just means white blood, and so too many white blood cells. We use the word chronic in medicine, we use the word chronic to mean long-standing over a long period of time, whereas I'm aware that colloquially, particularly in Nottingham, I think, the word chronic is often used as meaning really bad, but actually chronic means over a long period of time.
You know, what is the best treatment to give in the first-line setting, but also not just the first-line setting, what's then the best treatment to give in the second and third-line setting? And what does that sequencing look like? And you know, what if you started with another drug? Then what's the next best drug to give? So there's different aspects that one could look at.
This is a CLL cell. And CLL cells, they live in the microenvironment. They get boosted in the lymph nodes, in the bone marrow and the spleen. They circulate around. They speak to the microenvironment and get all of these activation signals, and they go out into the blood.
I don't want people to view me as a victim or somebody who's, and I do get that at times. I get people looking me up and down. Oh, you look well. And well, yeah, I am. I'm very well, thank you. And we all get that kind of thing. I'm very much, you know, the type of person that wants to carry on with life. I don't want to let things kind of get on top and defeat me. They have at times. You know, I've had some kind of, you know, lonely times, dark times where you get horrible thoughts about X, Y, and Z. Will I see my daughter grow up? You know, will I be able to work? You know, kind of longer term. But I think some of the stuff that we've all heard today shows that we're a pretty inspiring bunch of people, and we can get through kind of anything with the right support and the right help. So, thank you for taking the time to listen, and it's been great.
I'd had CLL since 2009, but I've been on watch and wait. So I felt absolutely okay until the pandemic came along, and suddenly I was extremely vulnerable, and suddenly I was having to hide away, and I just had to rework out who I was. And CLL support was fantastic during that time, and so when Mark said we want some more trustees, I felt I had to say yes.
Right, immunoglobulin mutation status.
And I just went out walking. I went walking wherever I could, whatever opportunity I did, I just went walking. And I always sort of, perhaps I'm running away from it, am I? But no, it just helped so much to get out of the house, in the open air. I have a dog, so that helped. But I was walking her, but I was also walking on my own, or walking with friends, or walking to the pharmacist to pick up my prescription, or whatever it may be. I was walking, and it helped enormously in my personal experience. Then, after 2 years, the doctors started talking to me about treatment.
So I presented all the data on IgG because before ibrutinib came along, IgG was sort of the marker that we looked for in clinic as to whether people would be more susceptible to infection or not. And that Danish registry that's just come out also picked out IgA as an important factor for predicting risk of infection. So I think maybe we've underestimated how important IgA is, and that's probably because in the context of a global immunosuppression, IgA might be more important if you've got an adequate level.
And you guys are dealing with the most scary thoughts and feelings ever, because they're about getting in the way of everything that matters to you, every person that matters to you. So you don't want them, and you don't like them. So you're constantly in a battle with yourself, and it's exhausting.
And they've just recently shared that data with us. I'm very excited about it, not because in some ways it gives us a particularly unique perspective. A lot of it you'll look at and you think, that resonates, I understand that. But what it gives us, a very comprehensive, detailed, data-rational view to help drive our strategy.
I could cross out wait and put worry, and I think that's a reasonable thing to do. There's no doubt that there is a concern when I go, well, you've got leukemia, limited information from myself, and then I go, and I'll see you in 6 months, with nothing else. And so what I've said, in my mind at least, and what I believe happens in my clinic, is that at my first clinic visit with a patient, I'll have a discussion about what CLL is, which isn't not that easy to explain actually, and also how we manage it, and then also contact details for this clinical nurse specialist. You might not meet the clinical nurse specialist on first day because they may well be very busy next door or whatever, but the thing is then there's email and there's the phone and there's the ability to come back and perhaps meet them in a slightly more relaxed situation at another time.
So in order to diagnose CLL, you need to demonstrate an abnormal population of B lymphocytes in the blood. So we all produce B lymphocytes that make antibodies and T lymphocytes that have a sort of different role in immunity, but they work together as part of our immune system. So when somebody is first found to have the lymphocytosis in the blood and CLL is suspected, this is a picture of a CLL blood film. So as one of the things actually I love about hematology is the interface between the laboratory and the clinical, and you diagnose the patient based on what you can do in the lab, and then you see them and you can treat them. So that for me is very, I like the sort of holistic nature of that.
You know, it's a big deal having CLL at every stage of the journey, and you're going to feel, you know, your life's turned upside down when you're given the diagnosis. We were chatting earlier, and, you know, to many people it feels like a bereavement, you know, the losing your old self. And you've got to kind of be in tune with that and just cut yourself some slack and realise that, you know, life is going to feel pretty shitty for a bit, but it will get better, you know. But just be kind to yourself, and if you feel you're overdoing it, tone it down a bit.
You know, one day you can get up, you feel really charged, you know, ready to go for anything, and then, you know, you go out there, and then I just have to say to myself, whoa, stop. You know, sometimes you can do a bit too much. So you've still got, as you know, Stella said in one of her slides, you've got to live healthily as best as you can, but you've also got to remember your body. You know, you've got to give your body a bit of slack as well.
Something somebody did say to me, which was interesting, was it turns everything you think you know about cancer on its head. You know, so it seems completely counterintuitive to be diagnosed with an advanced cancer, but then not to be treated. So, but I also found out that about 27,000 people in the UK are also on Watch and Worry. And I'd never heard of it before I was diagnosed. And the big thing, and Neil's already mentioned that, is that you don't know when anything's going to happen. You're constantly vigilant. You're waiting to find out when something's going to happen. Am I going to have to go into treatment immediately? All those sort of things. And I remember one morning, it was about a month after diagnosis, I got up and I had a shower, and it felt like the lumps in my armpits had got a lot bigger. And I caved completely. And this very nice lady, Tracy, sitting over there. I went in to see my consultant, and I had a meltdown in my consultant's office. And they said, no, you're okay. Things haven't moved. It was just my head making things out to be something that they weren't.
I've put together a number of slides to act as a framework, but at the end of the day, this is your session, so please interrupt, ask questions, do as you like. If you can manage to ask a question where I can't answer or say something, then you've done something nobody else has ever managed.
When a patient has CLL and we can detect it, there are probably a million cells in that patient. And if we reduce it by 1 million times, there's still potentially a million cells left, if you think about it. We can only detect a certain level of disease. Our test can only what's in the sample and how good our test is. And so we can, with our current test, go down to 1 cell in 100,000 cells, which is pretty impressive actually. And we might go down to 1 in a million in some patients and with some tests, but we're never going to be able to measure the last cell in the patient. Because we're not taking all the blood out and measuring all the cells. So we may not, it might be hiding somewhere. So we just can't measure every cell. So when we talk about MRD negativity, we're not talking about cure, we're talking about we can't find any disease. That could be the disease is here, just below the line, or it's gone.
I'd like to conclude with a short verse, I assure you it's short, that often goes through my mind whilst I'm on these walks. It seems to me to talk of the CLL journey as well as everything else. It's by talking, the road goes ever on and on, down from the door where it began. Now far ahead the road has gone, and I must follow if I can, pursuing it with eager feet, until it joins some larger way where many paths and errands meet. And whither then? I cannot say, but not yet weary are my feet. Around the corner I may meet a sudden tree or standing stone that none have seen but I alone. And though I pass them by today, tomorrow I may come this way and take the hidden paths that run west of the moon, east of the sun. So thank you very much.